Hello doctors, hope you are all well. Today I have started the Transplant Critical Care series in which we will discuss few interesting cases of lung transplantation. The Transplant Critical Care is an evolving subspecialty in which various fellowships along with a separate DM course is available in India. It is quite a challenging but interesting branch if one wants to pursue a career in it. In this video, I will cover few important issues in lung transplantation with the help of case vignettes which may give you some idea about the difficulty level of the MCQs. So here we go. For question number 1. 3 months post lung transplantation, a 50-year-old female patient is admitted to the ICU with complaints of increasing dyspnea, cough and low-grade fever. She is completely compliant with her drug regimen consisting of prednisone, tacrolimus, azathioprine, valganciclovir and trimethoprim sulfamethoxazole. Examination reveals bilateral crackles and decreased breath sounds over the left lower chest wall. Oral temperature was 38 degrees Celsius, heart rate 92, blood pressure 100 over 65 millimeter of mercury, respiratory rate 35, SpO2 91% on room air. Chest CT scan reveals bilateral ground glass opacities with a left-sided pleural effusion. Bronchoalveolar lavage reveals lymphocytic predominance and transbronchial biopsy is significant for dense perivascular and bronchial mononuclear infiltrates with a negative C4D staining. Which of the following is the best next step in the management of this patient? A. Intravenous methylprednisolone, B. Intravenous ganciclovir and piperacillin tazobactam combination, C. Intravenous immunoglobulins and rituximab combination, or D. Therapeutic plasma exchange. So my friends, here the patient experiences acute cellular rejection confirmed in transbronchial biopsy, which is a gold standard test to diagnose the rejection in a transplant case like this. Two main histopathological hallmarks of lung transplant of acute rejection in the lung transplant are the peribronchial mononuclear inflammation, also known as lymphocytic bronchiolitis, and perivascular mononuclear cell infiltrates. Despite the recent introduction of many improved immunosuppressive agents for use in the transplantation, acute rejection affects up to 55% of the lung transplant recipients within the first year after the transplant. Acute rejection is the most common type of rejection. Pulse high-dose corticosteroids are the mainstay of the treatment for symptomatic or high-grade acute cellular rejection. Therefore, option A is correct. 10 mg per kg of intravenous methylprednisolone is given daily for 3 days in such kind of acute cellular rejections. Other treatment options that have been used for acute cellular rejection include antithymocyte globulin, that is ATG, extracorporeal photopheresis, and alternative immunosuppressive agents such as alemtuzumab, sirolimus, and everolimus. Question may be asked regarding the timeline of acute cellular rejection. So, acute lung rejection classically occurs during the first year after the transplantation. The main differential diagnosis of acute cellular rejection include the humoral rejection and infections. Humoral rejection can be hyperacute rejection or acute antibody mediated rejection. Hyperacute rejection presents in the first 24 hours following the transplantation, and it is due to preformed donor-specific antibodies. The histopathological hallmark of the acute antibody-mediated rejection is the subendothelial disposition of C4D demonstrated by the immunohistochemistry. but it is not essential for the diagnosis. Specific treatment options for the humoral rejection include intravenous immunoglobulin, that is IVIG, therapeutic plasma exchange, rituximab and bortezomib. CMV pneumonitis is unlikely in a patient who is already on CMV prophylaxis with the valganciclovir. Therefore, intravenous ganciclovir in this patient is not warranted, and hence the option B is ruled out. Hyperacute rejection is primarily humoral because of circulating recipient antibodies that bind to the donor human leukocyte antigen molecules on the vascular endothelium. Acute rejection is primarily cellular, and chronic rejection is a fibrosing process. So pathophysiology of all these three types of rejections are different. Chronic rejection develops in the 50% of 3 to 5 year survivors and predominantly involves small airways, and it is pathologically distinguished by the bronchiolitis obliterans syndrome. Now we will move on to question number 2. A 65-year-old man with idiopathic pulmonary fibrosis is being listed for lung transplant. Which of the following is the most likely cause of death within the first week of lung transplant? A. CMV pneumonia, B. primary graft failure, C. post-transplant lymphoproliferative disorder, or D. bronchiolitis obliterans syndrome. Now here, 25% of the lung transplant recipients develop primary graft failure within 72 hours of post-lung transplantation, which is clinically diagnosed by the progressive hypoxemia due to pulmonary edema and radiologically bilateral pulmonary infiltrates resembling non-immune ARDS. It has a mortality rate of about 50%, which makes it the leading cause of perioperative deaths. The main reason for the primary graft failure is presumed to be a combination of various processes, in which the ischemia reperfusion injury is the most common cause of primary graft dysfunction or primary graft failure, and that lead to increase in the microvascular permeability. Second cause could be the surgical trauma, and third, the lymphatic disruption. Longer the graft ischemic time, more will be the chances of primary graft failure. Before making a diagnosis of primary graft failure, we should rule out the volume overload, pneumonia, rejection, atelectasis, and pulmonary venous outflow obstruction. The treatment is supportive with the protective lung ventilation, as we do in any classical ARDS case, and also extracorporeal life support in the form of ECMO. And if nothing works, then we have to list the patient for retransplantation. Cytomegalovirus pneumonia after lung transplantation is most likely to occur after first month of transplantation in the absence of antiviral prophylaxis. So choice A is ruled out. Post-transplant lymphoproliferative disorder PTLD has an onset after 6 months of the lung transplant in most of the cases, with the majority of the cases related to the Epstein-Barr virus. So choice C is also ruled out. The onset of bronchiolitis obliterans syndrome almost always occurs after a year of lung transplant. So choice D is also ruled out. Now we will move on to question number 3. A 55-year-old male patient is admitted to the hospital 7 months post lung transplantation. Since last 3 months, he has history of increasing breathlessness and inability to clear secretions. He is unable to sleep flat on the bed during the night due to dyspnea. On examination, he is afebrile with a heart rate of 88, blood pressure of 140/80, SpO2 of 94% on room air, and a respiratory rate of 30 per minute. Right-sided rhonchi are noted on auscultation. Initially, he did not respond to the albuterol nebulizations and therefore has been started on NIV, to which a marked improvement was noted within an hour with the reduction in the respiratory rate to 24 per minute. Which of the following is the gold standard test to diagnose his condition? A. Pulmonary function testing with the spirometry. B. Standard CT scan of the chest. C. Flexible fiber optic bronchoscopy. Or D. Sputum for microbiological analysis. So the patient described here has most likely developed the tracheobronchial malacia with or without bronchial stenosis, which will require visualization with a fiber optic bronchoscope. So the bronchomalacia is a chronic problem, is a chronic complication of lung transplantation. The malacia is defined as a greater than 50% reduction in the air volume during the expiration. It can be localized to the anastomotic site or diffusely affect the donor airways. Clinical features include dyspnea that may be aggravated in the recumbent position, chronic barking cough, wheezing, inability to clear secretions, and recurrent infections can occur. Spirometry may show a reduction in FEV1 and forced expiratory flow at 25% to 75%, but it is not a confirmatory test. So variable obstructive pattern may be seen in the flow volume loop. A dynamic CT scan of the chest may show the respiratory changes in the airway lumen, but a standard CT scan will not be diagnostic, so option B is ruled out and option A is also ruled out. The bronchoscopy is the gold standard tool for diagnosis of airway complications like this, including the tracheobronchomalacia. It allows for direct visualization of the dynamic collapsibility of airway during expiration. So a sputum culture would be very helpful to diagnose if the patient has a pneumonia, but the chances of pneumonia with the patient being afebrile and producing clear secretion is fairly low, so this is not the correct choice. So management of tracheomalacia can be challenging. Observation is recommended for most of the cases because asymptomatic cases are more common, but medical management is initially considered for the symptomatic disease, which involves the chest physiotherapy, mucolytics, and non-invasive mechanical ventilation, that is NIV. And more invasive options such as stenting and tracheobronchoplasty may be considered for the severe malacia, which is localized to the central airway. So this ends my video over here, but at the end of this video you would find few MCQs for you to solve, and the answers of which will be shared in the comment box. I hope that these kinds of video series will be very helpful for examining like you, and definitely it is a good way to discuss few challenging and difficult topics with you guys. I am very happy and teaching, and hopefully if you have any question in the future you can ask in the comment box, and if you would like me to make any further video on a different kind of topic, let me know. So that's all for today. Thank you very much. Bye bye.